All right, I need to quicken the pace a little bit. A lot of important information here, both in terms of your exam and also ICM and stuff like that. So we're going to go through anatomy. I'm not going to spend too much time with that. Hemorrhage, the occlusive vascular disease, hypertensive retinopathy, diabetic retinopathy. I'm not going to spend too much time with diabetes. I'll basically just, give you the highlights. And then macular degeneration. All right, so please make sure that you understand this. Here's the retina, the sensory aspect of the retina. Rods and cones. So we're going from superficial to deep. Superficial to deep, superficial to, no, I'm sorry. This is superficial to deep, going into the vitreous body. If you take this is the retinal pigment epithelium, RPE. That is what I will refer to as. And if you were to blow this up, the RPE, you need to know Bruch's membrane and the blood vessels of the choroid. This is superficial on the top of the retina. This is also known as the non-sensory part of the retina. The sensory part, obviously, are the rods and the cones. And then, of course, here is where the light is coming in. It'll be picked up, and then the nerves will take it through the optic disc. So this is all anatomy. You guys should know this. But as I said, right now, be familiar with RPE and Bruch's membrane, because we will see pathology dealing with that. All right, retinal hemorrhage causes hypertension, diabetes, and we will spend time with central retinal artery and vein occlusion and how it will differ. That's important. You need to figure out as to what the difference between arterial and venous occlusion is. You will hear about flame-shaped hemorrhage. What is a flame-shaped hemorrhage? When you have your blood vessels, remember you have two types of blood vessels in your eye. You have the central retinal arteries, which are coming through the optic disc into the vitreous body, and then you have on top the choroidal blood vessels. Please keep that in mind. As you go deeper, so the flame shape are the hemorrhages that are further deep, meaning towards the vitreous body. That's where the hemorrhage is taking place. It's flame shape. Those are the ones that you can see very, very easily. The ones that are deeper, meaning, I keep saying deeper, it's superficial. If it's more superficial, meaning going towards the RPE, then they end up becoming darker. Okay? Now, the first one we will speak of will be the central retinal artery occlusion. All right, this is common sense, a lot of physiology here. If you have an arterial occlusion, what do you expect the intravascular pressure to be within or further down in the capillaries, high or low? Low, low, low. Where's the occlusion? In the artery, prior to the capillaries, prior to the veins. Blood flow does not have an opportunity to reach the capillaries, so therefore the intravascular pressure in the capillaries will be low. If it's low, are you going to see congestion or are you going to see pallor? Is it going to be anemic? Pallor. Are you guys with me? If you have arterial occlusion, decreased intravascular pressure, you're going to have pallor. It's a central retinal arterial occlusion. You can have emboli that will break off due to thrombosis, cardiac issues, stuff like that. And when that happens, you might have an emboli which will travel up through the central retinal artery, occlude it, and when you have temporary transient, pay attention, temporary transient blindness, disturbance in vision, it is known as amaurosis fugax. You will hear that clinically. You need to be familiar with that term. How does that come about? You have a cardiac condition, you throw off an emboli. You have an AFib or whatnot, throw off an emboli. It goes up through your carotids, whatnot, and then eventually it reaches, right, your central retinal artery. Okay. And you have occlusion, and when you have a temporary sudden disturbance of vision, this is known as amaurosis fugax. All right. It is on the arterial side. The factors: size of the vessel involved, degree of ischemia, and the nature of the embolus. Size, degree, and nature. This is all central retinal artery. What is the lamina cribrosa? Lamina cribrosa is the little passageway that allows for the retinal vessels, I'll show you a picture of this, allows for the central retinal vessels and the optic nerve to pass into the orbit. So it's that little passageway. So think about that. If you have mechanical disturbance of the lamina cribrosa, you will be occluding possibly the artery, possibly vein, possibly nerve. I will show you a picture of this. Are you imagining this? As the vessels are entering the eyeball or entering the vitreous body, it is the lamina cribrosa. And if you have mechanical disturbance, you can cause compression of any one of those. If it's the artery, are you going to see pallor or congestion? Pallor. It's going to be anemic. If it's going to be venous, we'll see this in a second. It is beyond the capillaries, right? Beyond the capillaries. And if you have obstruction there, what's going to happen? Intravascular pressure. It's going to increase. You're going to see congestion. I'm pushing ahead a little bit so that you have an understanding so that we can get through this. But it's all a story. All right, let's take a look at this. Here's the lamina cribrosa. So here is the vitreous body. And this passageway right here is the lamina cribrosa. And what is passing through there? The optic nerve, the central retinal vessels. And if for any reason you have compression or there's inflammation of the lamina cribrosa, do you see as to how it's going to compress any one of those? And depending as to what it's going to compress, you will manifest certain conditions or symptoms. So, this is central retinal artery. All right, I got ahead of myself a little bit, but I need you to understand this. Cotton wool spots. You hear that all the time. Cotton wool. Little piece of cotton? No. It looks like cotton on a fundoscopic examination. What is that exactly? Well, central retinal artery occlusion. If you have an arterial occlusion, what is it also known as? Ischemia. All right. If you have ischemia of your nerves, you don't have blood supply to your nerves. What happens to your axoplasmic flow? Decreases, non-existent. If your axoplasmic flow isn't working, your mitochondria end up dying, and you have inflammation of your nerves. That's basically all that cotton wool spot is. All right. You can see it in a bunch of conditions. I'm not saying that it's pathognomonic for central retinal artery. However, when you see cotton wool spots, you know that it's ischemia which is taking place in which your nerves are being inflamed. Pallor. Well, with central retinal artery, obviously there's going to be pallor. We've come to understand that now. Cherry red spot. Where would you see this? What is the highest concentration of cones in your retina? Fovea. Yes, very good. Like that with confidence. Fovea. And so therefore, the retina is extremely thin at that part of the retina, of the eye. If it's extremely thin and you have pallor, what are you going to see? What type of blood vessels are you going to see? Your choroidal blood vessels? They're exposed, exactly. And that is known as your cherry red spot. That's what I'm trying to get at. It is the fovea, the thinnest part of the retina, in which there's pallor taking place due to central retinal arterial occlusion, and that pallor is exposing the choroidal blood vessels, cherry red spot. There it is, cherry red spot. So, differentials in your head that you'd be thinking about. Central retinal artery occlusion, this patient, some type of thrombosis. Okay. Permanent blindness. Please be careful. Do not underestimate this condition. Permanent blindness. So even though it looks pale, extremely dangerous. And what did we say about amaurosis fugax? What type of disturbance in vision? Long-term? Transient. Exactly. Very good. Transient. I'm sorry. I'm happy to do that. Transient. You guys didn't do anything wrong. Transient. Yes, please know that. Okay. However, if it's a central retinal artery occlusion, meaning that occlusion has become permanent, then you're possibly looking at permanent blindness. So we predicted as to what's going to happen with central venous occlusion. Central venous occlusion. Causes: diabetes, hypertension, atherosclerosis, glaucoma. And what do you expect the intravascular pressure to be here? High. I'm so high. And vascular congestion. Vascular congestion. What's interesting about this, however, so you have engorged blood vessels. Why? Because your veins beyond your capillaries are obstructed. What's interesting about this, however, is that as bad as it may look, the blindness is not permanent. Meaning that you take care of the occlusion, you take care of the blindness. Okay. Looks worse, but not necessarily. So here, a fundoscopic examination. See how congested that examination looks? The retina looks? On a gross examination, unfortunately, the individual's eye didn't make it. And then, of course, you can go through steps for venous. If it's partial and complete, it's non-ischemic. Non-ischemic. Yes, sir? I mean, as soon as you see something like this, for which one, venous or arterial? Well, I mean, as soon as you see something like this, I mean, you want to find out what the underlying cause is. So, I mean, as far as an actual time, I don't know. I guess it all depends as to how bad the symptoms are. Partial incomplete, or I'm sorry, partial incomplete, and then complete. If it's complete occlusion, then it's going to be ischemic. This is a picture of hemorrhagic, and what you're looking at here is all of these blood vessels here, or I'm sorry, not blood vessels, all of these blood cells, extravasation of your RBCs because of backup and congestion. Okay. All right, so we talked about increased increased intravascular pressure. Recovery can take place. It's sudden and painless. Painless. Not that arterial is painful, but point being is we'll come across glaucoma in which it's painful quite a bit. So stuff like this you want to pick up on. All right, so then here to summarize, number 1, normal. Number 2, if you see pallor, cherry red spot, central retinal arterial occlusion, and then central retinal venous occlusion, see congestion, increased intravascular pressure. Which one of these has the greatest tendency of becoming permanently blind? Arterial occlusion. Right? Okay. Hypertensive. Now here is something that, so that was central retinal vein, central retinal artery. Hypertension obviously can be a cause, and this is what I need you to pay attention to, please, because if you don't, you're going to miss the concept for the next slide. All right, so here is your artery, and this red, this column of red that you see is the blood which is traveling through the artery. This, the blue, is your vein. This is normal. And all of this is supplying your nerve. So therefore your nerve is quite happy. Now, say that you have arterial sclerosis due to hypertension. Look at that. The wall of the arterial has thickened quite a bit. And what I need you to understand is that the vein, the central retinal vein and the central retinal artery share adventitia. Adventitia. Now this is what you're going to see. This is pretty significant as far as hypertensive retinopathy, because what you see is the arteriosclerosis, and then take a look at that column of blood. It's thinned out. Okay, and what this will appear as on a fundoscopic examination is that normally it will be red. However, when it's hypertensive, this column of blood will appear as being copper wired or orange. Then, if the occlusion or if the thickness of the arterial is so bad that there's no blood traveling through it at all, then it will look like a ghost vessel or a silver line or silver wire. What's important here is the fact that since the arterial and the vein share a common adventitia, because of a thickening of the arterial, you have a kink or a nick. Where is that nick taking place? In the vein. However, the diameter of the vein itself remains the same. Before and after, the diameter of the vein remains the same. It's a thickening of the arterial which causes a nick. And we'll see this This is basically in words, that's what I just said. So if you see copper wiring or orange wiring, what's going on? Hypertensive, arteriosclerosis, thinning, column blood is becoming thinner. When it gets to a point where there's no blood traveling through it at all, because the thickness is completely occluded, it is a silver wire. Words. AV nicking is what this is looking at. So this is the copper wire. Is there a lot of blood flowing through there? No. No. What about thickness of the wall of the arteriole? Quite a bit. Quite a bit. And so what is it doing to the vein? Nicking it. What about the diameter of the vein before and after? Does it change? No. Why? Because adventitia is the same. It shares adventitia. Just more pictures. So if you see AV nicking in one of your patients, if they ask about AV nicking, if it's hypertensive. If you see cotton wool spots, what is that? Inflammation of your nerves. Why? Because there's ischemia. Central retinal artery occlusion. All right, please make sure you review this stuff, the high yield stuff. You're going to see this time and time again. All right, so arteriosclerosis, obviously, flame-shaped hemorrhage, dot blot. Technicality, all it is hemorrhage. However, it is more superficial in the retina, meaning that the hemorrhage actually takes place in the Mueller cells. Dot blot hemorrhage. Cotton wool spots, you'll see that here too. Why? Because ischemia is taking place. Inflammation of your nerves. Microaneurysms. Okay, diabetic retinopathy. I'll show you a picture of sorbitol. More importantly, advanced glycation end products. And I'll take you through, obviously, the ocular manifestations, because you guys should already know about age. And it's tractional. And I'll tell you why. You have three types of detachments, retinal detachments. And this type of detachment is tractional, and I'll tell you why in a second. All right, so this is the sorbitol pathway. There's increased glucose, diabetic. This is diabetic retinopathy. So think about what's going on, too much glucose. And so therefore, there's enough going through glycolysis. So it's going to take an alternate route, and that ends up being aldose reductase, and you form too much sorbitol. Not good, not good. All right, so that's it for that. But here, I love this slide. Kind of summarizes everything, and since we're dealing with retina, that's what I need you to focus on. So, diabetes, arteriosclerosis, hyperlipidemia, what is all this doing? It is causing occlusion, and you have retinal ischemia. That's nothing new. And if you have retinal ischemia, what's going on with the nerves? They're inflamed, cotton wool spots, loss of capillary parasites. We'll see this in a second. Microaneurysms, meaning that you have ballooning of your retinal vessels. And then eventually, if your vessels are dying out enough, you have certain factors which will come into play in which they will proliferate or develop or recruit more vessels. All right, so you have angiogenic factors, and this you need to know. Well, you need to know quite a bit, but angiogenic factors. And when these come in, these will trigger your blood vessels to grow further or recruit more, and this is known as neovascularization, quote-unquote, proliferative diabetic retinopathy. Prior to neovascularization, it is background or non-proliferative diabetic retinopathy. So what is a proliferation in reference to? The proliferation is in reference to the neovascularization. If you don't see neovascularization, it is going to be non-proliferative. Does non-proliferative precede proliferative all of the time? No. Because it is proliferative that is the dangerous one. That is the one in which you have increased development of your blood vessels. Why? Because the blood vessels are dying. Why? Because of diabetes. Why? Because of arteriosclerosis, ischemia. You need more blood vessels. If you have more blood vessels and they're coming in, they're going to pull the retina. Tractional retinal detachment. There's no memorization there. It's just a wonderful one. I mean, not a wonderful story, but in essence, as far as learning what's going on, it's a great story. All right, now this, where students get confused. Now, your blood vessel, normal width, you have your nuclei, and these are your endothelial cells. What I need you to pay attention to, however, is that you have parasites. Peri, what does peri mean? Around. Around who? The blood vessel. Okay? So here's your endothelial cell nucleus within the blood vessel, and then you have a parasite around the blood vessel. So now, excuse me, diabetes is taking place, and you have arteriosclerosis. What does that mean? Thickening of your blood vessel. Thickening of the blood vessel is not going to affect the endothelial cells so much. It's going to affect the parasite. And if you affect your parasite, or you lose, you obliterate your parasite, take a look at that. Your capillaries within the network, all of these are dying. There's severe ischemia which is taking place, and so therefore your ratio of endothelial to parasite is greater than 1. It should not be the case. When you have an endothelial cell, you should have a parasite. When you have a parasite, you should have an endothelial cell. When you have ischemia, well, guess what? Who's greater? Who's greater? Endothelial cell. Endothelial cell. These are normal. And then here's your parasite with the basement membrane. Arteriosclerosis has taken place due to diabetes or hypertension or whatnot. Your parasite is dying out. When your parasite die out, who dies? The blood vessels in between, the network, right? So if this is taking place, now what kind of factors are coming in? You need to recruit more blood vessels. Who's coming in? What type of factors? Angiogenic factors, right? And if the angiogenic factors come in, what type of diabetes is that? I mean, what type of retinopathy is that? Proliferative. Good. Thank you. And what kind of detachment will that result in? Yes, excellent. All right, so now in words, all right, microaneurysms. Microaneurysms are not quite, yes, the blood vessels are being disrupted, your ballooning of your blood vessels. However, they're not completely destroyed yet. Okay, so when you see microaneurysms, you can see them both. You can see them both in proliferative and non-proliferative. Mostly still in non-proliferative. So that area balloon. Okay, proliferative. We talked about this. Neovascularization, angiogenesis, okay? Okay, so make sure that you know the definition of both and what encompasses both. And then here, this is normal. Normal. Ischemia has taken place, arteriosclerosis. Who dies? Endothelial cells or parasites? Parasites. Parasites die, and so therefore you need to recruit angiogenic factors, VEGF. Vascular endothelial growth factor. That is, right now, a lot of research taking place and seems to be the player as far as neovascularization. So here's your existing blood vessel, and you have VEGF, and then you have new blood vessel. Do you see that? Do you see how it's moving into the vitreous? You see that? It's moving into the orbit? And what is it doing when it's growing in like that? Pulling. Fractional. More pictures, microaneurysms, non-proliferative, proliferative neovascularization, which is taking place. Neovascularization is what defines proliferative. More, dot blot hemorrhages. Are they further, they're superficial, correct? They're superficial, the hemorrhage, as opposed to flame-shaped hemorrhage. Cotton wool spots, exudates, you will see exudates. Because you lose, the wall becomes permeable. And so you have exudates, soft and hard exudates. You can see that. Get so bad that, this is normal, and then here's your cotton wool spots, little white spots. These are your dot blot hemorrhages and flame-shaped hemorrhages. So differentials in your head should already be diabetes, right? It should be hypertension. And then here's your microaneurysms, but then you have to be very careful. Remember I said, do you have to have non-proliferative before you have proliferative? No. It can be so bad in which all of a sudden you just have massive hemorrhage. Bottom right. Okay. That particular individual has gone blind. Blind. Hard exudates, microaneurysms. Non-proliferative. Proliferative. Why? See these little, you have to take a look at this. Little blood vessels that are in there. That's neovascularization. They're not supposed to be there. That's because of diabetes. Ischemia has taken place. Let's picture for your reference, and here, this is your neovascular membrane. more proliferative. All right, in that case scenario, 32-year-old male of East Indian descent comes to your clinic seeking medical advice for experiencing stomach growls in spite of having voracious appetite. He also experiences excessive sweating with the feeling of passing out, which is almost instantly relieved after devouring a Snickers bar. Bathroom habits of urinating have increased in frequency, and so has a requirement of fluid. He is concerned that he might be developing diabetes due to positive family history from both sides of the family. If this patient were to go on to develop diabetic retinopathy, which of the following enzymes is theorized to be responsible for causing? So this is more or less the type of question that you'll be looking at. Okay. Case scenarios, case scenarios, case scenarios. What do you think? What do you think the product is? Sorbitol? What's the enzyme? Aldose reductase. All right. So here, joys of life, enjoying your grandchildren, enjoying your children, nephews, whatnot. And I'm stuck. There we go. And diabetes, severe hemorrhage, not so joyous. So please be careful. I have an aunt actually who's going through something like this, and she's so incredibly stubborn. Scary. Retinitis pigmentosa. Now with this, there are two things that I need you to pay attention to. Tunnel vision. This is what it is in reference to. Tunnel vision. Night blindness and tunnel vision. Basically, the peripheral visual field has been eliminated. Okay. Now what happens is that, you remember the retinal pigment epithelium? Superficial. What is more superficial to the RPE? What type of membrane? Brooks membrane. What's behind or posterior to the Brooks membrane? Choroidal blood vessels. Okay. So we talked about two types of membranes. Where do we see Descemet's membrane? We saw it in the where? Cornea, right? Yeah. And this is Brooks membrane. Brooks membrane is the posterior part of the retina, or superficial part of the retina. I'll show you a picture of this. And then retinal pigment epithelium. There's a reason I'm telling you all of this. Retinitis, inflammation in the retina, pigmentosa. Accumulation of pigment within the sensory retina. So, as you would see with cataracts, age, you have deterioration of your lens. Here, in this particular case, there's deterioration of your RPE, retinal pigment epithelium. What does it contain? Pigment. And where is it going? It's going into the sensory retina. Who's the sensory retina? What type of cells are in there? Cones and rods? Yeah, cones and rods. Okay. I just need you to understand that, and importantly, identification on fundoscope. Because you have release of your pigment. What's the name of that pigment? Melanin? How about that? Yeah. All right. So you have release of your pigment, and it surrounds your blood vessels. When it surrounds your blood vessels, it looks like little spicules of bone. And this is what I'm talking about. This right here, these little white lines are spicules. It's probably not the best picture, but the reason that we talked about tunnel vision and night blindness is that the rods will be destroyed first, then the cones, and if you destroy your rods, what type of vision are you affecting? Night vision, so night blindness. And as we said, the melanin will accumulate or surround your blood vessels. These are known as your spicules. So this right here is your melanin. It's a dark object. You can actually see with Usher syndrome. So please make sure you know that. Usher syndrome. You see an elderly patient who, nerve deafness, whatnot, retinitis pigmentosa. All right, normal. And here are these spicules. This is probably a better picture, fundoscopic examination. melanin, you expect it to be darker. And this pattern is known as spicule. RP is retinitis pigmentosa. And that's basically all that you need to know for retinitis pigmentosa. Picture on your far left, deterioration of your RPE, and it goes into your sensory retina. All right, let's go into age-related macular degeneration, armed and dangerous. 2 million people possibly affected back home. Most common, MCC is the most common cause of blindness among individuals of European descent, and average age about 65. All right, so here was that RPE I was talking about. Here's the Brooks membrane, and here are the choroidal blood vessels. All right, and what's interesting about this? All right, so where's the macula in relation to the optic disc? Temporal or nasal? Temporal. Temporal, meaning lateral, right? All right, that's where the macula is. And center of the macula, I think we already answered this prior, was you have the fovea. All right, thinnest portion, highest concentration of cones? Yes. And the reason that I had this picture on the right was that, interesting enough, nature has made it that you have xanthophylls, because nature realizes of the two, the cones and the rods, the cones are probably more important as far as color, that kind of thing. And so you have xanthophylls, which actually protect the cones. So if you take out the xanthophyll, you'll actually have the cones that you can see. Point being is macula, fovea, greater concentration of cones. Now, this is where I need you to pay attention, please. There are two types, the dry and the wet. Okay. Now with the dry, essentially what ends up happening is that your RPE, the retinal pigment epithelium, ends up being destroyed. Okay. And not just your RPE, but also your Brooks membrane. And this is a dry, because when you have the Brooks membrane and the RPE which are being destroyed, you have accumulation of a substance between the two layers. The accumulation of that substance, the mucopolysaccharides, are known as drusen. That's what you need to know. Dry, why? Because I'll tell you in a second, but you see dry drusen as far as ARMD, age-related macular degeneration, between the retinal pigment epithelium and the Brooks membrane. I'll show you a picture of that. Now, as the condition gets worse, all right, you have further degeneration. And just like in diabetes, you have neovascularization. You also have neovascularization with armed. And when this occurs, well, the blood vessels are extremely fragile. New blood vessels. All right, they're weak, they're young. They need tender love and care. And when they don't receive it, they're going to be permeable. All right, and that is your wet or disciform type of ARMD. All right, so initially, once again, your RPE and your Brooks membrane degenerate, accumulation of mucopolysaccharide, that's your drusen. And as neovascularization takes place and you have fragile blood vessels, they leak, and that is your wet or disciform. And that is the one that's dangerous. All right? Because, I mean, if you have hemorrhage and bleeding, are you going to have good vision? No, absolutely not. All right, it's macular degeneration. And we'll see what it looks like through the eyes of a patient with ARMD. All right, so now that we have